First, I'd like to thank the kind invitation and to congratulate the organizing committee. Many things will be repeated, but still new things will be spoken. So around 50% of the patients with TAA are suitable for this graft. If adjunctive procedures are employed, this figure can rise up to 80%. Apparently, with identical technical success, despite increasing procedure time. Still, there are limited situations that are not at all suitable for the graft, as my colleagues told. For example, a post-dissecting aneurysm with a very narrow lumen and bad target vessels. We'll go through in this presentation through all these items. The excess vessels, if narrow, heavily calcified and tortuous, may not allow for insertion of a graft and may lead to rupture, dissection and thrombosis of the excess vessels. Adjunctive procedures to overcome these complications are sequential dilation, balloon angioplasty, the construction of an iliac conduit, either by open or endo, and having the low-profile 18 French graft available. Unfortunately, it's not off the shelf. These are pictures of open conduits and endo conduits. And this is our standard access with purse string sutures. And this is one of our cases with occlusion of the right iliac and the stenotic left. So we did a femoral endarterectomy. There was here a big plaque in the common femoral artery. Okay. Can we play the other also simultaneous, please? We did an endarterectomy of the femoral artery, a stenting of the external with a covered stent, and an uncovered stent in the common, so that we managed to preserve the hypogastric artery. This is a control angio of a T-branch with an occlusion of the right iliac limb. The external iliac was dissected, and this was managed with femoral endarterectomy and extending the stenting proximally. This dramatic case occurred when removing the sheath of the T-branch. We ended with the iliac artery on the stick, still the purse string sutures you can see here. This rupture was promptly controlled with aortic balloon occlusion and followed by deploying the stent graft, the unibody and the limb to the groin, and then joining the femoral artery to the stent graft with a surgical conduit. This same patient, after removing the sheath from the arm, the 12 French sheath, the brachial artery was pulseless and the artery was all dissected. So we had to re-enter and stent it all the way from the arch, and at the surgical access interpose a vein graft. Moving to the aorta. Severe angulation, a narrow lumen and previous implanted aortic grafts may cause a lot of trouble. There is insufficient trackability, poor steering, and as a result, poor branch alignment. Previous stents may be dislodged, and the graft may be not fully deployed. And as a result, branch cannulation may not be possible. Adjunctive procedures to overcome this anatomy are the use of a through-and-through guide wire, the driven by the shaft maneuver, pre-cannulating branches before fully deploying the graft, and in case of having collapsed branches, dilate them sequentially. My colleagues have told about these dreadful complications, so just to remind that the graft can be loaded in the sheath in a twisted fashion. These 3 markers on the back should be on the front, okay, along with the tick marker. So be aware of this, orientate the graft outside and inside the patient in lateral view, and correct for twist during the deployment. Shaggy aorta. If it is massive as this one, this patient would be unsuitable for the procedure. If it is not that massive, one can go, but be aware and be ready for thrombosection or stenting as a bailout and have a meticulous technique. Moving to target vessels. Complications include unsuccessful cannulation, perforation, dissection and thrombosis, kink and thrombosis, embolization. So the standard technique, as has been told, uses 2 sheets, the 12 and the 7 for stability, and relining as necessary. Agentive procedures have been told, also the snare right technique, and pre-cannulating target vessels before completing the deployment of the graft. Vessel perforation occurs when one loses track of the tip of the wire and it enters small terminal branches, or if one is using stiff guide wires, except apart from exchange guide wires. As a bailout, balut tamponade, coiling and extending the covered stent. This is a case which is not ours for coiling of a branch. This is a case of a renal artery perforation, which on CT shows a small pseudoaneurysm. And this is a case of an apparently normal SMA, but with this stain, which was not directly connected to the SMA, but in the angio, there was this pseudoaneurysm from an SMA branch. Vessel dissection. This is a case of a left renal artery occluded at the end due to dissection, which we further extended till we couldn't go any further and have to use a kissing stent with coronary stents to achieve this result. Branch kinking. This is mostly an issue in renal arteries. The branch stent is an advantem, and we can notice 2 kinks at the ostium and then again at the end of the stent. This was improved with relining. So late branch complications are mostly due to stenosis and occlusion rather than endoleaks. And this is a case of an occlusion of a right renal artery, despite an apparently good control angio. Notice the posterior orientation and the sharp takeoff of this artery. Attempted recanalization was unsuccessful due to technical error. This is another renal artery occlusion that occurred 1.5 years after the procedure, despite a good control angio and a good CT at 1 year. Extra anatomical bypass was done for both renals. It was patent. The patient resumed diuresis, but still had to be put on dialysis for life. So, regarding branch kink and occlusion, be aware of tortuous vessels, of posterior oriented right renal arteries as that one, of upward going renal arteries, and these avoid long bridging distances. Use short stents and relining as necessary. This paper compares custom-made to T-branch grafts. Branch occlusions only in renals and only in T-branch grafts, despite it's only a few patients and a short follow-up. This other patient groups BVARs from several types, and notice that most of the complications are either branch stenosis or occlusions, and at the top is always the renal artery. Intervention rate is really high. Spinal cord ischemia. Well, it's the dreadful complication. Its incidence increases as one increases the extension of aortic coverage. Other predisposing factors are occlusion of the left subclavian and hypogastric artery, renal dysfunction, preoperative hypotension, and long procedure time. So the immediate it can have a presentation that is immediate, or it can have a delayed presentation, usually up to 3 to 10 days, but can be even longer. And usually it is preceded by hypotension. The deficit is mostly motor, and if this deficit becomes permanent, survival of these patients is poor. Prevention and management is mostly addressed at increasing the spinal cord perfusion, so having cerebral spinal fluid drainage and maintaining adequate blood pressure, adequate hemoglobin, and adequate oxygenation. The planning should consider preserving left subclavian and hypogastric arteries, and if necessary, revascularize them. Have the shortest thoracic coverage possible. For this purpose, there is this custom-made device that allows for achieving a proximal landing zone with only 84 millimeters long. So it's shorter than a standard TVAR tapered graft. Staging the TVAR and DVAR of the procedure is documented to lower both paraplegia and mortality rates. Other ways of staging the procedure are embolizing the intercostal arteries and leaving branches open and stenting or close them afterwards. Usually it is the celiac artery branch that is left open or an iliac limb. During the procedure, it is important to remove the sheets from the artery as soon as possible to restore perfusion. For this purpose, the purse string sutures or the surgical conduit is important. In conclusion, BVAR is safe and effective. Complications can be avoided or anticipated with careful preoperative imaging and planning, good intraoperative imaging and meticulous technique. Troubleshooting and bailing out from complications require good imaging, a robust endovascular inventory, and proper skills. The branch failure mode is more related to occlusion rather than endoleaks. Renal arteries are the target vessels more prone to occlusion, and spinal cord ischemia is a devastating complication and can have an immediate or delayed presentation, and its prevention and management is critical. Thank you.